Okay, welcome again today to attend today's webinar in SPHR webinar for Health and Risk Communication series. My name is Zhao San, a research fellow at University of Birmingham, and I'm very delighted to be chairing this session. We are joined today by Dr. Marco Bardus, who will be delivering a talk entitled Risk Communication and Community Engagement. So let me briefly introduce Marco and today's session. So Dr. Bardus is a assistant professor in public health at the University of Birmingham. His research focuses on digital health communication and behavioral change, particularly the development and evaluation of theory-informed interventions using mobile and web-based technology. He has worked extensively across international projects addressing the prevention of non-communicable disease and the strategic use of communication in health promotion. So Dr. Bardus is also the convener of this SPHR network for health and risk communication for public health, and he leads the efforts to foster this interdisciplinary dialogue and practice in health and risk communication. Also, worth mentioning, he serves as the mentor, my academic mentor for the ESRC-funded research fellowship, and he provides incredible, valuable guidance on my project. So in today's session, Marco will explore the critical role that risk communication and community engagement plays in responding to public health stress. So drawing on the experience from global health emergencies and field research in emergency contexts, Marco will highlight the strategies for effective risk communication, building trust, and fostering meaningful community dialogue and actions. So today's presentation will also touch on evidence-based approaches to risk communication and community engagement, with particularly attention to the equality, inclusivity, and cultural relevance. So Marco will have approximately 30 minutes, and I'll give him a 2 minutes warning before the end of the presentation. So Marco, over to you right now.
Hey, thank you very much. I hope you can hear me okay. Good afternoon, everyone, or good morning or good evening, depending on your time zone. So the purpose of this meeting today, of this webinar, is about exploring the critical role of risk communication and community engagement in responding to public health threats. So I'd like to start by giving some definitions, or asking you to find some definitions of risk communication and community engagement, and then looking at some frameworks that we would use in these contexts. And then I'd like to look at the principles of effective risk communication, try to think about what makes risk communication effective in different contexts, and then take a look at some exemplar applications based on what we remember, maybe from recent applications of emergencies. And then we talk about, I want to finish this webinar with some discussion on proposals of research, newer research ideas or areas of research investigation. So start from the question, what is risk communication? So try to Google. So ask Google, what is risk communication? And then you can pop the response into chat. Maybe someone wants to talk about that. Maybe you can intervene. Let's try to make it a bit more interactive. Anyone is a quick on their keyboards, maybe? So I said here Gemini. Gemini is the AI version of Google. Basically, it gives you the first response in the in Google. Okay, so I see here, Julia, thank you. Risk communication is the real-time exchange of information, advice, and opinions between expert officials and the public about potential threats to their well-being. It aims to enable informed decision-making. Yes, yes, excellent. I see also Zhang, ChatGPT. Okay, risk communication is process of exchange information, advice, and opinions. Very similar, I see. And Jessica, exchanging information about risk between expert and the public, and individuals making informed decisions. Okay. And then Opeyemi, Nana, exchanging information advice. I see. I like the fact that ChatGPT gives you the bold element. So thank you for that. Okay, so you notice that there's some similarities in this. And if we go to the official definition, let's say, we have, I propose here three definitions. One is from the US Department of Health and Social Services, Services, from 2002 to 2005. So risk communication is an interactive process of exchange of information. So it matches what ChatGPT and Google Gemini provided. So it's exchange of information and opinion among individuals, groups, and institutions, which involves the dissemination of information, basically, about health risk. Now, there is another version that is developed by the CDC, so the Center of Disease Control and Prevention, the US one. So risk communication integrates risk and emergency approaches in order to prepare for, respond to, and recover from epidemics, outbreaks, and so on. The last one, which I like more, it looks a bit more comprehensive, is the one from the World Health Organization, which is very much similar to what ChatGPT and Gemini give you. So it's a real-time exchange of information, advice, and opinions between experts and officials about an hazard or a threat. To enable that's the key aspect, to enable informed decisions to mitigate the effects of the threat. Okay. Now, there's a distinction we need to make in this context between health risk communication and communication of health risks. So health risk communication is a field of practice and research that involves the strategic development, delivery, and evaluation of messages, in order to inform decision-making and influence behaviors. Communicating health risk is where I think the first definition here in the chart refers to. Hold on, the third one, Jessica, about experts and the public and helping individuals make informed decisions to manage potential hazards. So the context of communicating health risk might be very much aligned with the individual relationship with a healthcare provider. Okay, so in this context, we're not talking about communicating health risks. The difference between the two approaches is that the scope, the approach, and the purpose are different. So health risk communication, which is the topic of today's webinar, is about a strategic theory-driven field applied to public health, usually focusing on participatory approaches, a two-way collaboration between different entities, different stakeholders, that is aimed at influence decisions, build trust, and reduce harm. So to, in a sense, minimize the effects of an outbreak or a hazard, a disaster, So there are different examples called the RCCE. We talk about that in a few minutes. Now, communicating health risk as an approach within health communication is really generally focused on an informal, unstructured approach, one way or two ways. For example, looking at the way that GP, general practitioner, discusses the risk with a patient. Okay, this is something different. I've been working on these areas to some extent with some colleagues in the Department of Psychology in Birmingham. But we're not talking about this in this webinar. That could be a topic for another webinar. So communicating health risks is another element. So from a communication standpoint, there's a difference also between crisis communication, risk communication in crisis and emergency risk communication. From the perspective of the communicator, the timing of the communication, the perspective of the message purpose, you'll see from this table some nuances, let's say. So in the context of crisis and emergency risk communication, which is the one we're talking about today, the communicator is usually, an expert who is impacted by the outcomes. The timing is urgent and unexpected. So an outbreak happened, we need to respond immediately. We need to respond urgently. And the purpose of the message is to explain, to persuade, and to empower decision-making. We need to be clear, we need to be, giving advice to people. Now, from an historical, so the difference between crisis communication is that it's usually managed by communication departments, public relation departments in organizations. They usually discuss a problem or an emergency from the perspective of the organization. Think about oil spills or the ExxonMobil crisis that happened many, many years ago now. So what happened is that crisis, that unexpected event, involves an organization. Think about now Air India for the disaster of the airplane. So that event, that disaster affects that organization particularly. So the focus is very much about managing the organization communications. And so Boeing on one side, Air India on the other side, and the pilots involved in the crash, and the airport that allowed the plane to take off and so on. So risk communication, usually in general, is looking at the expert who is not directly impacted by outcomes. And risk communication is very much a strategic approach planned in advance. So you're not reacting to something. You're not reacting to a crisis or an emergency situation. You have prepared that for that long ago. And I'm gonna go through this approach in a few minutes. Before we go there, I want to give you some sort of overview, a historical perspective of risk communication as a discipline. So here I put I search terms for health communication, risk communication, crisis communication, health risk communication on PubMed yesterday, and I saw this like spike in publications that mention those terms. Okay, so health communication is the broader discipline. And risk communication appears quite later, let's say in the 90s, around the 90s. And if you focus here on the terms of risk communication and crisis communication, you see similar developments from the 90s onwards. The 90s and the early 2000s represent a moment of shift towards more proactive approaches and preventive approaches to risk communication. Think about what terrorist attacks might be, and different pandemics or outbreaks of SARS, the West Nile virus, avian flu, Zika, but also terrorism. So we talk about different type of problematic elements. Sorry, someone is advancing the slides. So, okay, someone is moving the slides. Okay. Risk communication involves, on one side, risk assessment, which is science-based, evidence-based, risk management, which is policy-based, or understanding what resources are available. And then there's risk communication, which is about the interactive exchange of information and opinion concerning risks. Now, over the past 20 years, I would say, there have been the different risk communication frameworks were developed. So we have one to mention is the COMBI, which is not the capability, opportunity, motivation. This is the communication for behavioral impact. Was initially developed by the WHO around the 2000. That was superseded by the emergency risk communication framework, and then finally the risk communication community engagement, what you can see there. The United States, the Center of Disease Control Prevention, developed their own framework, which is the CIRC, which is Crisis and Emergency Risk Communication. I'm going to talk briefly about the CIRC, which is the most recently used also, and the RCCE in a few slides. So the CIRC is really a framework to develop a response on emergencies. And it's about engaging the community, empowering decision-making, evaluating, of course, but at the same time, it goes through stages or phases. We have a preparation phase in which you draft and test messages, you develop the strategy, and you create plans. You determine the processes needed to inform the public and engage with the public. Then you have an initial phase in which you respond to the emergency, to the crisis. You're expressing empathy, explaining risks, promoting action, describing response efforts. Then there's a maintenance phase where the outbreak or the crisis being somehow controlled. Then you can still mitigate some of the potential impacts of the outbreak by minimizing the risks, identifying areas of intervention by segmenting audiences, providing background information to those who are in need, and addressing rumors to minimize misinformation and disinformation. Finally, you have the resolution where you have, the outbreak was contained, you are returning to a normal situation, so you can still motivate vigilance, can discuss lessons learned, and revise the plan for the future. Now, the CIRC rhythm is based on 6 principles, which are be first, be right. To be first meaning you need to provide a response, a timely response to an issue, to an event, to an outbreak. Be right. You need to provide accurate estimates. You need to ensure that you are credible. Be credible, of course. Be honest and truthful. Express empathy when needed, because you know that in situation of crisis and uncertainty, people tend to respond to the basic fears and emotions. So expressing empathy is particularly important here. Promoting action. So behavior change or behavioral action, action-oriented messages are very important, no matter what. And then showing respect, because of course people might make different decisions. So if we wanted to apply the 6 principles of CIRC to the COVID-19 pandemic, and we have to look back at the table. Think about in your context, in your country where you are from, in the country where you lived in, what were the messages, right? So in terms of the communicator, the expert was impacted by the outcomes. Do you recognize any of these? So in some situations, some countries, here I'm not politicizing the issue, but it has been politicized, so it's worth considering, worth remembering what the early days of the pandemic were, where political figures were out there giving advice, and they were not experts. Yes, they were impacted by the issue like everybody else, but they were not experts. So different countries reacted differently, probably, and you remember that. And then, so this is the New Zealand case, when you have the prime minister with an expert talking and giving a press conference. So think about who was the spokesperson, who was the messenger delivering the information to the public. In terms of message purpose, the CIRC rhythm talks about explaining, persuading, and empowering decision-making. Look at these 2 different messages. Again, I'm not criticizing a particular country, but it's worth considering these elements. So stay alert, control the virus, save lives versus protect the NHS. These correspond to different phases of the pandemic, reasonably. At the same time, they prompted some inconsistency in the response, perhaps. And lack of consistency is perhaps, for this is a press conference with the Italian minister at the time. And then we have the example of the United States, when mask mandates were not recurred, where they were not introduced, or were also faced with some reluctancy from the president himself, So these are the things we need to consider. So the message, the communicator, the purpose of the message, and the clarity of this information. So this, to give you a context for the emergency risk communication and risk communication community engagement framework on the WHO. These are the building blocks. So we need to ensure credibility, trust. We need to provide technical information as possible, and we need to be driven, by values and expression of care. So we need to show the empathy that we saw before. So in terms of credibility, people need to know what you care for them, and then credibility is partially influenced by the reputation of the organization. So you need to be very careful who's decided to speak on behalf of an organization. It could be a state, right? It could be a hospital. It could be a public health organization. It could be the local authority, right? So the person that needs to be speaking has to be credible, reputable. Experts can be involved. They need to be, associated with the issue, and they need to show empathy, of course, because this will generate some trust in individuals, trust in the organization. If the organization is not trustworthy, then the message that comes from them will not be considered valid. Then, of course, technical information, providing clear action guidelines, okay, of action points, what you need to do, when you need to do it, where you can find this information, and guiding people to follow the advice. Now, there's been work, of course, done from different researchers and colleagues, part of the WHO. So in the past 10 years, basically, they converted the emergency risk communication approach into the risk communication and community engagement. And these, I show you here 2 slides representing the response that was prepared for the action plan, the risk communication community engagement plan for COVID-19. There was an effort to coordinate the efforts globally. Now, what is RCCE? RCCE is just a series of activities that different public health organizations, the ministries in particular, are carrying out to target individuals and groups, not in communities, so not on individuals, and at household and community level. So here is about really much of a system approach to risk communication. So it's of course managed by organizations that have the mandate to protect individuals' health and well-being. And of course, it's a bit different than the traditional risk communication approach because it's very much built on participatory collaboration and dialogue, trust building activities, and empowerment of decision making. So there are seven steps in the RCC process. I will highlight the main elements here. So the first one is about data collection assessment. When you do service maps, stakeholder mapping, network analysis, formative assessment to understand the needs of the population. And this should be done before the outbreak of the pandemic. So this is the preparatory phase. Then you have the workshop and strategy when you have a multi-sector collaboration and dialogue. You define the roles. And so in case an emergency occurs, who's going to take charge of what tasks, what activities. Then you have the messaging development, the community engagement activities. Then you have the equipping of the staff, so training of staff, field workers, data collectors, emergency responders. Then you have the two-way communication, which you feedback in the loop. You adjust and adapt the based on the feedback and the iteration, and finally you close the loop when you learn the activities and you understand this. Of course, this is very similar to other approaches. You can maybe identify some similarity with social marketing or social behavior change communication. Now recently rebranded as social behavior change, SBC. SBC is promoted by the UNICEF as well as some fringes of the WHO and the International Federation of Red Cross, Red Crescent. However, some researchers also hypothesized a way to operationalize RCC as a framework, right? So we have the steps. At the same time, these steps need to be done in different ways in different times. Well, you can see here in this graph, you have the outbreak that activates a response. But that response, that communication, the networks, the monitoring evaluation elements have been planned ahead of time, right? And as you can see then in the left side of this graph, in the non-emergency phase is when you do the training, when you do the staffing, when you develop the SOPs, you develop the strategy, you do exercises. So everybody needs to be ready to act when the outbreak, when the crisis, when the disaster happens. Now, I have a question for you all, of course. Is RCC effective? So it's generally considered effective, right, in terms of curbing public health emergencies. And there's been research done on this field, on this area. And for example, there's a joint evaluation of the RCC collective service done after the pandemic. So as you can see here, as UNICEF, the WHO, the IFRC, which is the International Federation of the Red Cross and Red Crescent. So based on the collaborative partnership, they developed a series of activities conducted, I think, between 2020 and 2023. They developed guidance, they developed tools to assess, to monitor and evaluate the actions and so on. They provided robust collaboration between different areas, different EMRO regions, sorry, different WHO regions, including Eastern South Africa, Western Central Africa, the Middle East, and so on. They introduced a data for action approach, which means an evidence-driven approach, monitoring approach to inform. They mentioned a dashboard here to inform RCC response. They did a lot of capacity building, a lot of training. So having spoken with the IFRC people responsible for the Middle East in Jordan, they said they've gotten a good experience and they have been trained so many field workers and staff. However, this approach has been considered a top-down and was considered with some confusion to some extent, and there was a major problem of funding. Then I asked my colleagues, is there any evidence of behavior change? And the answer is, we don't know. We cannot detect. We can only reflect on the experience we had after the pandemic. Because we said, well, we contained the pandemic. We contained the outbreaks in different areas. We then introduced the vaccine. So there was a lot of work done in that area in engaging the communities in making the vaccines more acceptable, debating debating the issues related to the non-acceptance, the hesitancy. So overall, they say, well, we had an impact, but it's more of about a feeling about it. There's no actual evidence of behavior change. So that brings me then to the new areas of research. These are my ideas, let's say, based on some readings, of course, and work that I've done with the IFRC and WHO. So we need to develop standardized indicators that would assess and identify behavioral health outcomes to evaluate the impact of any initiative that includes risk communication. Now, which framework should we use? It doesn't matter, as long as we can determine that there's a framework, there's a strategy that is being done, that was being developed before an outbreak. Okay, if that's the case, then we can say, well, if we hadn't done that, we probably would have been much worse. We need to establish the cost effectiveness and scalability of these initiatives, because in the case of the joint effort with the WHO, IFRC, and UNICEF, they spent $1.6 million. So it was a lot of effort, a lot of money was invested in training, but we don't know if that translates into an impact in saving lives, in reducing hospitalizations and deaths, and so on. And we need then to investigate if we keep on doing RCCE, so if we keep on engaging the public, the different groups of people involved, does this translate into civic engagement, health system resilience, social change? Would this improve things? So we need more evidence, okay, about this. We need to evidence on effectiveness on analysis interventions. Here I just propose a few potential research questions, and then a methodology could be done to do this, to answer those questions. So what RCC strategies are most effective? How do we specific channels influence outcome differently? So from a communication perspective, we want to know what messages are effective, who's the messenger, so the source of information, and how messages were framed, and probably about the process, understanding how with these messages were developed in the first place. Were they following a framework for community engagement, for example, a participatory approach? So we don't know this. We don't know very well the impact of this. And then, of course, if we're looking at equity and inclusion in research, so how well this approach of RCC that is done on paper, let's say, is supposed to be engaging the communities, but is this approach sufficient to reach marginalized groups, refugees, people with low literacy? How are they included in the process? Okay, how are they involved, not just included, involved in the development of the strategy itself? So to some extent, are public engagement and involvement activities included in developing strategies for risk communication and community engagement? We don't know. Or how well are they doing it? And what strategies are really accepted, and how are they accepted by different communities? Okay, so and then of course here we can think about qualitative studies, we can do about evaluations, we can do content analysis of messages, and to ask whether the content, the message itself was resonating with some cultural values or perspectives of different target groups. So I came just to give us some ideas here, and I'm open, of course, for brainstorming more. And so this is the end of my presentation. So I hope I used about 25 minutes. So maybe you can use a bit more time for debate or discussion, maybe based on the comments from the chat, or if you have any questions that people want to ask. I see one here from Priyanka. Okay, so has anyone worked on using RCC in non-emergency health risk communication, like say vaccine hesitancy in communities with low uptake? Yes, I mean, off the top of my head, I know there's been some work on this area. I think, well, depends on the context. If I'm not mistaken, in Jordan, so from the WHO EMRO region, so Eastern Mediterranean Regional Office, I think that's been doing some work with UNICEF in Lebanon and Jordan, so the Middle East, the Levant, with the vaccine hesitancy. But this is a problem, I think, that goes beyond the emergency, as you said, non-emergency vaccine hesitancy is, so childhood immunization are problems that have been even before pandemics or outbreaks. There've been recent outbreaks in the UK for measles, so the issue about vaccine hesitancy is highly on the agenda. But of course, we need to probably contextualize. Are there other questions or any ideas or things where you would like to see more research on risk communication? More questions or comments? Someone wants to speak? I think we can allow interventions. Otherwise, I have questions for the audience. Oh, Priyanka.
Hi, this was
Hi.
really interesting, Marco. I I did my PhD on public perception of on the influence of communication on public perception of water fluoridation. So this resonated a lot with me, and I was thinking one of the things that I found during my research was that the source, or rather source of information, might be perceived as credible by some people while it would be perceived as not credible by other people.
Mhm.
So there is a lot of division on that. So what I did was I tried to map what people's sources of information were on water fluoridation, and I mapped it with the evidence hierarchy, the pyramid.
Mhm.
And I found that, of course, the information accuracy of the information improves as you go up the pyramid, but people are not aware of it. And then the perceptions of credibility vary, and that's how they form their opinions. That much I found in my research. And I thought that the people whom we can influence, be it water fluoridation or vaccine hesitancy, there are certain people who have staunchly made up their mind and nothing will say will ever matter. It
Mhm.
doesn't matter. And they are the, let's say, activists kind of people, the anti-fluoridation, anti-vaccine
Mhm.
activists.
Mhm.
But there is still an undecided group which is constantly seeking information on the topic, and
Yeah.
that's the group that health communication can influence. But I've noticed that health communication is not consistent, while
Mhm.
the conspiracy theory communication is consistent.
Well, that's a very good point you raise here. So, in a sense, it's we as health communicators are not consistent in the approaches, probably in the way we respond to issues. I agree to some extent to the fact that sort of we need to adapt our response to different scenarios, different contexts. So, of course, I would say it's very banal to say, but it is context specific sometimes. So the issue itself matters a lot, and people might have different opinions about different issues, different threats. They might believe in conspiracies related to vaccines, but they might not do the same for water fluoridation. So really need to delve into the belief system. And there's a way to do so, of course, by doing um, focus groups, interviews with different people. And I think the key strategy here is to segment the target groups. So understand the different, so you already mentioned that there was the hesitants, the ones who are still unsure, right? These you need to understand more about this uncertainty. Whereas those who are completely opposing the views, you already know what they think. There's nothing that you could do to convince them. So there's a different strategy for those who are imposing, making bans and forcing them to do something, even though they don't want to. You cannot convince them. Those who can, so you can persuade them, you cannot convince them. You need to work on the convincing element for those who are undecided. Okay, so I think the efforts for this communication, should be directed to those who are really uncertain and undecided, which might be most of the population sometimes, because think about a novel virus. Nobody really knew what happened. Nobody really knew what the consequences were. Nobody knew about the vaccine. There were no vaccines at the beginning, so there was a lot of uncertainty. And of course, we learned by probably doing mistakes. Now, I hope that based on those mistakes, we can prepare better. So from the dialogues I had with the IFRC people responsible for the RCCE strategy development, they feel they are prepared. However, I'm not sure. I mean, we cannot just do an RCT and test whether, you know, in an area we create an outbreak, in an area we don't create an outbreak, we compare the response. I think that would be unethical, but there are ways we can test whether using RCC approaches, frameworks, or plans will make a difference at all. But I think the key aspect is about understanding very well the people, what they think, what their belief systems are, what the reasons for refusing a vaccine or refusing a product, water fluoridation product. So I think your research is spot on.
Thank you. Needed that before I publish.
Yes, of course. Publish, please, and publish to high impact factor journals. So you need to make sure that this research you've done, it reaches a wider audience. Okay, and I think we'll be happy to diffuse this information through the network we have. Okay.
Thank you. That would be great.
Now I see, Julia, social networks have empowered the voice of common people, and as a result, many false opinions have gained considerable reach. How to prepare for this using those frameworks? So Julia, are you talking about social networking sites specifically?
Not really. Like thinking about COVID, what we faced with those false information and the politicization of everything. It was something that was difficult to face, especially in countries where the government was doing things without specialists. So people felt they were like right, probably right. So I'm thinking now with all this experience that we had from COVID, like in future outbreaks or other health issues, how we can ensure that we like face this in a more direct way, like going to, you know, forums or platforms and trying to identify that and try to, you know, as you said, show evidence for people and try to convince them, although it's very complex and the belief systems and everything else involved. But I think COVID may had prepared us for this. So thinking about those frameworks, is there something that tries to anticipate that, or we're just going as it evolves? So.
No. So I think RCCE, so the Risk Communication Community Engagement Frameworks, follows the different steps as I showed you. And there's an important phase in which you really much is the first one, you collect data, you listen to. I mentioned in the slides, but very briefly, about social listening, which is an approach using social media to listen to rumors, for example. This has been done, and there are different WHO entities and networks that do that. So there are organizations, NGOs mostly, that connect with the social media discussion or debate, especially to detect rumors. And even in the CERC framework, you need to address rumors, because then the rumors become bigger and then become misinformation. People become say, well, this I've been told by my friends whom I trust. So if they said so and they haven't verified the source, but that's another story, I believe that, right? So identifying these networks, which is real networks, but also social media networks, so social networking sites, information spreads much easily on those, and we saw that in the recent pandemic. We talk about infodemic, right? Probably you've heard about this term before. So it is an essential issue. So it's about social listening to what the people say, what people express. Of course, there would be a small proportion of what people actually do, probably, but still, it might be indicative of what the rumors are, what might be some misinterpretation of and misconceptions that you need to address. And health communication is supposed to do that. It's supposed to address misconceptions and in a timely manner. So we need to identify them, understand what they are, understand what you can do to overcome those. I just mentioned here a project we did years ago with the IFRC, the Lebanese Red Cross. In Lebanon with Syrian refugees, we developed a WhatsApp group that included information, that diffused information all related to COVID-19 from UNICEF, WHO, the local Ministry of Public Health, and translated those messages from English, somewhere already in Arabic, somewhere in English only, translated into Arabic, and then automatically transformed them into text-to-speech. So it was a work done with the American University of Beirut, where they have a computer science department who helped us do this translation of the messages. And why did we do that? Because we wanted to reach the most vulnerable population in the country, Lebanese, in the country of Lebanon. So Syrian refugees living there in tented settlements, with weak internet connectivity, that were not able to access information. And they wanted to receive information that was reliable, was credible, and was verified. So we provided this service to them. They were very pleased to do so and to share this information with their networks, because they tend to use WhatsApp, of course, like many of us. And so when you talk about this kind of information, not everyone has a mobile phone, but not everybody is able to read. So we translated the messages into audio to reach a broader audience. So we had a good response from this point of view, in the sense that then this project would then use for the local Red Cross to deliver more information about health and productive health later on. So it is possible to do it, again, by the understanding from the target audience what they really need and what they really want. A long response probably to a quick question.
Yeah, thank you.
Yeah, thank you. And Winda, why is it important to use an intersectionality-informed approach in RCCE, and how can it be applied practically in the field? That's a big question. Winda, do you want to comment on this, or do you want to elaborate on this? I think you raise a very important issue, which probably connects to the piece I mentioned now about engaging people that are vulnerable, and there are multiple levels of vulnerability. So this has to come, I think, from the perspective of the organizations pushing for a solution in this case. So RCC should come not from the individuals and the groups involved, but RCC is supposed to be, in principle, participatory. So the more participatory are, the more wide is the network you are engaging with, the better response it is. You need to identify the niche groups that are probably affected by multiple levels of crisis or problems related to inequity and vulnerability, as I mentioned. To practically apply this in the field, it's about really going down to the fields, involving probably gatekeepers from the community. We worked a lot closely with Mukhtar, which are the heads of the camp, Syrian refugees, and women, in that case, in Lebanon. Women who are the sheikhas, that's like the equivalent of the sheikh, is the head of the chief of a camp. And the Mukhtars are the heads of municipalities. Those are the gatekeepers. They have power, not from a political standpoint, but from the charisma, the managing. They are leaders in their groups. So identify those leaders is very important, and then engage with them throughout the process of this strategy development from day one. Engaging in a conversation, not just considering them as research subjects or participants in a focus group. That doesn't work. Okay. Other questions, comments? The Q&A, maybe? No, I don't see that. And I can go back, oh, sorry, here. Maybe I propose here some areas of research. These might be potential PhD projects or research projects. building on, I think, Winda's question, how well does RCC reach marginalized groups? At the moment, we don't know. And what are cultural appropriate strategies to engage communities equitably? And then maybe we can embed this intersectionality. So education, sex, gender, power dynamics. How can this be really enforced or embedded in this research? And looking at the effectiveness then, again, the problem here, when we talk about effectiveness, usually we have an intervention and a comparison or a comparator group. It's hard to have a comparator group when you have situations like a response to an outbreak. You have, of course, areas where there's an outbreak, areas where there's no outbreak. And the ideal intervention would be RCC training in both areas. You can say, well, in the area where the training was occurred, the response was this. In the area where the outbreak was not present, the response was none. So that's the problem when you do this kind of comparison. And we cannot, as I said before, from an ethical moral perspective, you cannot randomize people to receive training or to receive information or to receive a disease, right? That's not a viable solution. But then within the context of an outbreak, some areas, geographical areas, might be exposed to some messages versus others. This is where you can test the effectiveness of some messages or response. But overall, the strategies should be applied to the whole area for equity. What do you think about this? Is anybody here who has heard the term realist evaluation or realist synthesis? From the silence, I guess, no? What does ChatGPT say, or what does Google say about realist synthesis? So realist evaluation is not the same thing, okay? As a tradition, this is to understand how and why interventions work and don't work in specific context, yes. That's realist evaluation, but realist synthesis takes a look at the evidence, published evidence, to answer the same question. So what is the mechanism? What is the outcome? And what is the context that makes a difference? And usually it's somehow, systematic review, to approach how and why intervention work, particularly in complex contexts. So it's not as simple as a scoping review. It's a bit more nuanced, and you want to get information from different sources. You want maybe interviews with experts, with people that have been affected by the issue. So in this context, we will need to do a series of documental analysis of opinions, try to understand the theory from the theory of change, not the theory of behavior change. A logic model. What are the activities that somehow, or the mechanisms that prompt an outcome, that generate an outcome, and in which contexts? So for example, what are the messages that work best with hesitance, vaccine hesitance? What strategies work best for vaccine anti-vaxxers? Very few probably, but there might be, if you use this segmentation approach or perspective. So in this case, the realist approach to evidence synthesis takes the question, why does it work? Not if it works or not. Is this effective or not? I think there is an issue here. I think we need to establish the effectiveness of RCC, so the approach itself first, and then we say, what does it work? Because we claim that these approaches work, but we don't know why, or we don't know to what extent they are really working. So we need to have a bit more nuanced understanding. Right. I'm still have 5 minutes, I think. Are there any other questions, comments, or suggestions of areas where you would like us to cover as part of the network? Okay, this is a question from Zhuzhang. Okay, are there any guidance on how do you balance the urgency of delivering information in real time with the need to ensure accuracy and cultural sensitivity? Oh, this is a $1 million, £1 million question. I think part of it is about planning this in ahead before time. So if you follow a proper risk communication community engagement framework, you would prepare for different outbreaks, different problems, and you can have information that you can share if this happens. So like algorithms, if the outbreak happens this way, if this is the outbreak, this is the virus, this is what you should say. If this is not a viral outbreak, this is what you should say. So you can start providing accurate information that has been validated as accurate before. And of course, the cultural sensitivity, you need to pre-test, evaluate the messages ahead of time anyway, all right? And so there might be a ways to do it quickly, and usually these are done by planning in advance, doing rehearsals, doing drills. There's a test outbreak, what happens now, what we're gonna be. So testing the process, yeah, it's a way to do so. And like for everything, for any other kind of form of communication, you need to evaluate the content as well as the message and the source with the target group. I cannot insist that's enough. So I see Kioma, the Israelis approach is a way for organizations working in health and other fields to truly evaluate their work. Yes, even though it tends to be done mostly by research institutions. So in a sense, impartial, to some extent, impartial partners in this evaluation. Because you were not involved in the approach itself, in the implementation, so you can somehow provide a bit more impartial evaluation of what happened and an explanation. But I think the best realistic approach, realistic evaluations, are based on the fact that you're involving the stakeholders, I mean the organizations deploying the campaigns with the target groups. Yes, so thank you, Amy. So if you have suggestions for future topics and feedback on the webinar, please send an email to sphr.coms@ncl.ac.uk. We will post on social media as well, probably links to this or the forms. And of course, you can remind you to stay connected, because we are announcing soon after summer, so for probably October, November, December, other 3-4 webinars. At the moment, we are in touch with a couple of colleagues, so we have at least 2 that are being planned. So if you want to follow our page, that will be, so the announcement will be done soon. Thank you, Leslie. Good to see you.
Yeah, thank you. It's been great. Learned a lot. Yeah.
Okay, great. Thank you very much for participating. Yeah, any final remarks, Zhuzhang?
Yeah, thank you for taking the role. Just for the Q&A session. So thank you again for Marco to provide this. I mean that's interesting, valuable, and also interactive presentation. And also thank you to everyone who joined us and contribute to today's webinar. So as my colleague Amy shared, if you have any feedbacks for the webinar so far and for the future topics, please just send us to the email that's shared, sphr.coms@ncl.ac.uk. And if you'd like to learn more about our coming events, the opportunities to get involved or to catch up on previous sessions, you can just visit the link that we'll share in the chat box. And also Marco has already shared our webinar website and also the YouTube website webinar series. So thank you once again for being part of this network, and take care. Goodbye for now. Thanks.